Hey everyone, it's Dr. Ida Khan. Welcome back to Medicos Guide. Today we'll be carrying out a detailed discussion and an examination of various types of reflexes found in our body. Let's first talk about the definition of reflex or reflex action. So, reflex or reflex action is an involuntary or automatic, unplanned action and nearly instantaneous movement to a stimulus. Reflexes are found with varying levels of complexity in organisms with the nervous system, and a reflex occurs via neural pathways in the nervous system called reflex arcs. We'll be discussing about reflex arc later in this video. And before we proceed, I have a humble request. If you enjoy my videos, please consider subscribing to my YouTube channel. Your support means a lot and it will truly motivate me to create more content for you. Also, if you have any suggestions, I would love to hear from you. Your feedback is always welcome and appreciated. Now, which reflex hammer are we going to use? A queen square neurological reflex hammer with pointed tip for superficial responses is preferred most of the times, as its flexibility allows us to apply just the right amount of force to elicit a response from those reflexes. Now let's dive into Introduction to Reflexes. It was first documented in 1875 by Wilhelm Heinrich Erb and Carl Friedrich Otto Westphal. The deep tendon reflexes play a vital role in the examination and diagnosis of neurological disorders. These reflexes, more accurately termed the muscle stretch reflex, are instrumental in assessing conditions affecting the afferent nerves, synaptic connections in the spinal cord, motor nerves, and descending motor pathways. The presence of hyperreflexia or hyperreflexia is considered a definitive indicator of neurological dysfunction. Now let's dive into its mechanism. A reflex arc serves as the involuntary pathway through which tendon stimulation triggers a muscle response. This arc is classified as monosynaptic, involving only two neurons, a sensory neuron and a motor neuron, connected by a single synapse. The sensory neuron, originating in the dorsal root ganglion, that is DRG, innervates the muscle or Golgi tendon organ. On the other hand, the motor neuron, located in the anterior horn of the spinal cord, initiates the efferent response. The process begins within the muscle spindle, a proprioceptive organ sensitive to muscle stretch. Comprising intrafusal fibers, the muscle spindle is embedded within the muscle and surrounded by a connective tissue capsule. Upon muscle stretch, the spindle detects changes in the length, activating 1A afferent sensory fibers that transmit signals to spinal cord. Here, they monosynaptically stimulate alpha motor neurons, initiating muscle contraction via glutamate neurotransmission. This contraction resists the initial stretch, leading to reflex extinguishment, that is, decrease in reflex response. Now, during the reflex, the antagonist muscle undergoes inhibition while the agonist muscle contracts. Polysynaptic inhibition via the 1A inhibitory interneuron suppresses the alpha motor neurons to the antagonist muscles. For instance, in the knee jerk reflex, the hamstring muscles are inhibited, allowing the quadricep muscles to contract. Additionally, gamma motor neurons within the muscle spindle modulate intrafusal fiber sensitivity via acetylcholine release. Now let's talk about the first class of reflexes, that is superficial reflexes based on spinal nerves. Now let's move on to demonstration of our first reflex, that is plantar reflex. But first we are going to discuss about the pathway and the method to elicit this reflex. So the pathway is afferent pathway, tibial nerve, center L5S1. Efferent pathway is by the tibial nerve as well. Now the method to elicit is bring the patient into supine position, gently scratch the outer border of the foot with the blunt object. From heel towards the little toe, then medially up to great toe at metatarsal level. And the response will be plantar flexion of all toes. Now, what is Babinski sign? This is a neurological reflex where the big toe bends upwards and the other toes fan out when the foot of the sole is stimulated. It can indicate upper motor neuron lesion or the damage to the central nervous system, such as the brain or spinal cord. But it can also be physiological, as it is seen in infants below 1 year of age because of the myelination that is occurring throughout the first year of life. Then it can also be physiological or normal during deep sleep and inhibition of the pyramidal tracts. Now, to assess the Babinski sign, use a blunt instrument such as the handle of a reflex hammer to stroke the sole of the foot from heel to the base of the toes. A normal response is for the toes to curl downwards. But an abnormal response in adults will be when the big toe extends upwards and the other toes fan out. Now let's move on to next reflex, that is abdominal reflex. It has a root value T7 to T12. Now it is divided into 3, so the upper abdomen has a root value T7 to T8, middle has T9 and T10, lower abdomen has T11 and T12. Now in order to elicit this reflex, bring the patient into supine position, abdomen will be uncovered and the muscles should be relaxed. Now stroke briskly but lightly in a medial direction across the upper and lower quadrant of the abdomen. The normal response is contraction of underlying muscle with the umbilicus moving laterally and up or down depending upon the quadrant tested. Now the next reflex is scapular reflex. It has a root value C5 to T1. It is assessed by stroking skin in the interscapular region and the response is the contraction of supra and infraspinatus muscle. Now, anal reflex, it has a root value S3 and S4. This is assessed by scratching the skin near the anus, and the response is contraction of anal sphincters. Now, cremasteric reflex, it has a root value L1 and L2. It is assessed by stroking the skin, that is, upper and inner part of the thigh, and the response is the contraction of cremasteric muscle and the ascent of testes. Now, bulbocavernous reflex, it has a root value S3, S4. This is assessed by pinching the dorsum of the glans penis, and the response is the contraction of bulbocavernous muscle. Now, the next category of reflexes is superficial reflexes based on cranial nerves. The first reflex here is the ciliospinal reflex. First, let's talk about the pathway or the reflex arc. Afferent pathway C234, center T12, efferent pathway cervical sympathetic. Now there are lots of other names for this reflex and these are pupillary skin reflex, cutaneous pupillary reflex, pupillary reflex dilation, pupil dilation response, reflex pupillary dilation, cutaneous pupil reflex, or skin pupillary reflex. Ciliospinal reflex is characterized by rapid dilation of the ipsilateral pupil by 1 to 2 mm with a painful or startling stimulus. It is elicited by scratching or pinching over the skin at the side of the neck, upper trunk, and face. This reflex, which was first described by Birch, is present in normal awake or sleeping humans as well as in the comatose patients. The name denotes the involvement of ciliary body and the spinal cord. As the mediation of this reflex is by the cervical sympathetic fibers, it is absent in Horner syndrome. Now the next reflex is conjunctival reflex. Corneal and conjunctival reflex both share the same pathway. Afferent pathway by the cranial nerve number 5, that is the trigeminal nerve. Center is in the pons and the efferent pathway is by the cranial nerve number 7, that is a facial nerve. Now this reflex is elicited by touching the conjunctiva with the cotton wool swab. Response is the contraction of orbicularis oculi muscle, due to which there is rapid closure of the eyelid. Now the next one is corneal reflex. Now as we have already discussed before that corneal and conjunctival reflex both share the common pathway. Now let's talk about how to elicit this corneal reflex. So touch the cornea with a cotton wool swab at its conjunctival margin and the response will be the contraction of orbicularis oculi muscle, that is rapid closure of the eyelid. Now next is the palatal reflex. Its afferent is carried by the ninth cranial nerve, which is a glossopharyngeal nerve, and the efferent by the 10th cranial nerve, that is a vagus nerve. Now this reflex is elicited by tickling the back of the pharynx with the swab stick, and the response is the reflex contraction of the palatal muscles. Now let's discuss grading of reflexes. The grading scale that is used for scoring reflexes was provided by National Institute of Neurological Disorders and Stroke, that is NINDS, in 1993. This is a standard scale for evaluating deep tendon reflexes. This scale has been validated and is universally accepted. Now the grading of this scale is as follows. At grade 0, reflex is absent. At grade 1, reflex is small or less than normal. It includes a trace response or a response brought out only with reinforcement. At grade 2, reflex is in the lower half of a normal range. At grade 3, reflex is in the upper half of the normal range. At grade 4, reflex is enhanced, it's more than normal and it includes clonus if present, which optionally can be noted in an edit, a verbal description of the reflex. Now in some instances, a plus sign positive is written after a number. When discussing DTRs, adding or omitting a plus sign doesn't change the meaning of a reflex grade observed. Now, what is normal typically depends on the patient's history and past documented reflex grade. Abnormality is suggested when asymmetric reflexes are found. Once the examiner obtains a reflex on one side, they should test the same reflex on the opposite side for comparison. And that wraps up today's video. Feel free to ask any questions related to this topic in the comments section below. If you haven't subscribed yet, click the subscribe button and hit the bell icon so you won't miss any new videos. If you enjoyed my video, don't forget to like and share it with your friends. See you in my next video. Until then, take care.